Good morning, everyone. Thank you so much for joining us today, and welcome to the 2011 International Forum on Quality and Safety in Healthcare in Amsterdam, Holland. My name is Susan Mumme, and I'm the Senior Vice President for Quality and Healthcare Improvement in Alberta Health Services. And joining me today is my colleague, Dr. Michael Auld, an anaesthetist at the Grey Nuns Hospital in Edmonton and co-chair of the Medical Staff Engagement in Quality Working Group in Alberta Health Services. In addition to the many excellent presentations you'll be hearing today, we're also very fortunate to have the opportunity to sit down with three leading international experts in the area of quality improvement to get their thoughts and advice on some of the challenges we face in improving quality and safety in a large healthcare organization. It's my pleasure to introduce our three panelists today. Dr. Goran Henriks, who is both the chairman of the Forum's Strategic Advisory Board and the Director of Learning and Innovation, Jönköping County Council in Sweden. Mr. Jim Easton, who is the NHS National Director for Improvement and Efficiency in the UK. Welcome, Jim. And Dr. Gary Kaplan, who is the Chairman and Chief Executive Officer at the Virginia Mason Medical Center in the US. Dr. Kaplan is also a board member for the Institute for Healthcare Improvement. Welcome, gentlemen. So just to set a little bit of the context for you for what Alberta Health Services is in Canada, we're responsible for providing healthcare to 3.7 million Albertans within the province of Alberta. Our services span the full continuum of care, primary care through acute care, community and continuing care. We have approximately 120,000 dedicated professionals, physicians, staff, support staff, and volunteers. But as an organization, we are fairly new. Almost 3 years ago, we formed following the merger of 13 health entities across the entire province. And from a geographical perspective, we're over 600,000 square meters. So rather large geographical footprint in Canada. And our view really is to look at how we can achieve patient-focused transformational improvement across our organization. We have three overarching goals for the organization: quality, safety, and sustainability. With such a large and geographically diverse patient and provider base, we need to translate and apply the principles of large-scale change or system transformation throughout our organization. But these changes need to happen at the local level. So given that, let's start with our first question. How do you establish an effective balance between the need that we have to achieve aggressive system targets for improvement with the need to support local ownership and engagement in quality improvement?
I'll happily start because it's such a direct parallel with the situation we find ourselves in England, which is a collision between a national economic crisis and the need to drive efficiency in our healthcare system, and a desire to promote bottom-up quality based on a journey led by our experience through things like the forum and our work with IHI based on engagement and improvement technique. And I think part of my job is to try and not describe it as a battle between top-down and bottom-up. We have two very immature models of change in England. One is someone at the centre will tell me what to do and will beat me to death if I don't do it. Targets. You get results, but you lose engagement. And the other immature model of change, which is leave us to get on very locally, and we'll get loads of engagement, but goodness me, it'll take a lot of time and we won't get spread. And developing the maturity to kind of get over those two opposites and say, ask the real questions, which is, how do you create a joined-up system of change? What is it that only the centre can do, and it should do it? Set a vision, provide resources, set clear objectives. What is it that people can do locally, drive local change? And what is it that you need to do to join those two up? Provide systems of support, have the two interacting so that the top-down messages are communicated and connected with the feelings and aspirations of local people. Provide training, education, make people feel empowered and supported. And it's difficult to do, because culturally, and I'm guessing here, but it sounds a little to me as though you've got the same thing, which is that people feel a little beaten up and resentful about the changes that have happened to them, and that's certainly true in England. And so there's some repair work to do. Quality improvement is a great vehicle for working through that process of bringing people back on board, associated, as I say, with this clarity of what is it that only the centre can do, what is it that needs to happen locally, and what can we do between those two to join up and support that change.
Great.
I think it's quite the contrast with the United States, where we have a very fragmented system, very little centralized direction. Frankly, we could use more centralized direction. At Virginia Mason Medical Center, we have what we call our must-do measures, which are the targets that we are seeking to improve. We have 140 must-do measures, and we those have been brought into the organization from external bodies. So somewhere in the public reporting domain are so many diffuse metrics, many of which have questionable validity. So I think one of the things that's critically important in establishing the balance is to make sure that there is open dialogue between the people on the front lines, the people at the local level who are implementing change and need to have a vision for their healthcare organization, their patients, that framework, and those policymakers who are thinking at a much more global level. And I think oftentimes that dialogue breaks down. And what you get is you get fragmentation, you get people working at opposite purposes. And so we need to really spend the time it takes to work on that and work on that dialogue and create a shared vision. Much as I know you have in your country, Goran.
I think we need a new language in the management and governance work, where we also get words for innovation and learning. We have a production logic, and there we use lean as a very important language, or Six Sigma, and then we have our business language, where we have a lot of finance indicators and things going on in our systems. But then we also need a management for the innovations. Where are the new designs of the processes? How do we develop prototypes that can be useful in the new context that we live in? And it takes time to develop that language, and sometimes owners and politicians do not accept that it takes a little time. So therefore it is very crucial to keep the engagement and passion for work in focus on the local basis, because otherwise you become so, you only play defense, and no one wants to play defense. And I think we need that leadership that helps people to have passion for the daily work.
I have a question for you about leadership. What leadership, and that includes operational, physician, and executive, actions and behaviors would you see as key in enabling the kind of large-scale system change we're undertaking?
For me, leadership is a wide word that is hard to really squeeze down to some concepts. But one thing I usually think of is that you have the coach you deserve, you have the leader you deserve. So leadership develops through how the employees look at their own work. And there is a relationship between the management and the employees that has to be discussed, because you cannot be better than the team plays. And this is so crucial, because if the team do not want to perform, then it's very hard to be chief in that situation.
That's actually a fantastically insightful point, and I can think of organisations who are quite broken, who keep getting leaders who break them more. That's a very, very insightful point, as ever. In difficult times, I mean, I would start, instead of leadership behaviours, with authenticity. I mean, there really is no point, given the challenges that we're facing and you're facing, people standing up and saying this is all absolutely fine and easy and will be a completely positive journey. There are positive parts of it, but I think acknowledging the challenge and the history and the difficulty is where you start to earn an understanding that you're on the journey with the people you serve as a leader. You're not just imposing some appalling solution. I think leaders at all levels have to share a game plan, and if the game plan is improvement, then that's about training, understanding, and we have organisations that have achieved that, and they're wonderful, and we have organisations where some people think that's the game plan, and other people think the game plan is beating people to death or avoiding the problem or not looking at the data. And you know, I mean, you're not a soccer nation, but in England we had a Swedish coach for a while for our soccer team. He was a fantastically brilliant coach, but our players didn't understand the game plan, and we had the most talented players we'd ever had, but the game plan wasn't shared or understood, and we failed. So if improvement is the game plan, and I think it's the only show in town for the kind of challenges we face, then the task of bringing people on board with that is crucial. And, by the way, by doing that, you build commitment. Because it's an energising response to a problem, you build people's confidence and their willingness to lead. And the third thing I'd say is just resilience. You know, there is no version of the journey for you or for us that goes from where you start to your end point in a smooth, linear journey. There are going to be fantastic steps forward, but also setbacks and crises of confidence. We're going through one right now, as I speak, in England, in the political sense, with the plan for reform for the government going through a spasm of lack of confidence, and that's part of change processes. And so a commitment to the end point, to purpose, resilience through that, a shared game plan and authenticity. Doctors in particular spot inauthenticity straight away, and you're lost as soon as you do it.
So I have a lot of thoughts on this question because as a chief executive and as a leader both of my organization but also of a team of leaders, I think about this a lot, and I think it starts with, well, first of all, I think the thing that has to be very much kept in mind is that our behaviors as leaders determine the culture of the organization. And so we talk a lot about culture, and I believe that the improvement work that you are on in Alberta, that we are all on in our organizations and in our countries, is really about change management, and it's about taking a culture of which I'm a product and very proud of that, but changing it and helping it to evolve. And so I think it starts with behaviors that engender trust. And I think that as leaders, there is almost a default attitude about us that is one of mistrust, that people tend to mistrust authority. And so I think that you have to really work at building that trust, and that involves communication. It involves showing your vulnerability. As Goran said, it's not about the leaders up here and the people are down here, but we all have a common objective, a shared vision of what we're trying to accomplish together. And then what we do on a day-to-day basis, whether you're an operational leader, an executive, or a physician leader, I guess there are some days where I feel like I'm all three, and the behaviors, because the signals we send through our behaviors tell people in the organization what's acceptable, what's important. So if we're working on improvement and on safety, for example, as the number one thing, in my opinion, is we have no business talking about quality if we can't keep our patients safe, the foundation of quality, then we have to behave that way. We have to lead by example. I think we have to continue to speak to that shared vision and create urgency, not manufacture urgency, but help people understand today's reality. And sometimes as leaders, we want to make people feel good. And so we may not be as willing as we should be to shine a bright light on the opportunities for improvement and on how much better how proud we are, how good we are, and how much better we need to be for our patients and our communities. So I think this is a critically important question. I think there's so much we as leaders can do. And maybe go back to, I think it was Collins' work, where he says, he describes level 5 leaders, fierce resolve. I get tested every day. Do I really believe what I say I believe, and will I really have the fortitude to stick to it, as well as humility. I mean, there's so much we don't know. And I think combining those things are really important, and that's what we try to develop in our leadership team. Not always easy, but that's what we're working on.
We're working to build our organizational capacity and capability to improve so that we can achieve long-term sustainability. How have you built this capacity and enhanced capability for improvement at all levels in your organizations?
I think you should start.
Well, it's something we work on through our work at Virginia Mason, where we are very focused on long-term capacity for improvement. Not during my tenure as CEO or during the tenure of this current leadership team, but in perpetuity, hopefully, that we are able to, and so it means training. It means that we have to prepare the people, prepare our staff, provide opportunities for growth and development so that people aspire to take on more responsibility and to grow as leaders. It requires clarity and truth telling, which is again very important and something that leaders have not always been willing to do. And I think that investing in people and developing talent is not something that comes easy in healthcare. You know, there's the traditional training methods, which are kind of the apprenticeship of the cottage industry that we've been for centuries in medicine. But we can learn from other industries and other companies, world-class companies that develop talent very explicitly. And we are working to try to do that, and because it's somewhat counter to the cultural upbringings of our physicians and our leaders, it's challenging but very important. And I guess the thing I always keep in mind is we went into healthcare because we wanted to be in the healing professions. Whether you're a finance person who's trained as an accountant, you could go work in lots of other industries that might be easier in some ways than today's world in healthcare. But everybody's in it because we want to help people, and I think keeping that in mind and appealing to the better nature of our people will help us prepare them for their leadership roles in the future.
In our system, we are very aware of the problem that historically knowledge development has been to go to a course or a program and go home and do what you always have done. So we have tried to develop an approach where learning comes in focus, and learning in the meaning that what is important is how you can contribute to the patient's results and to the system results. And because of that, you need to define the gaps between how something works and how well it can work. And if you can encourage and give people passion for looking at their own gaps, you minimize the conflict between knowledge development and competence development. So can every day becomes your competence development and capability development. You have taken a big step to a learning organization. For this, you need this kind of measures that Gary talks about. You need a system that has a theory of what is good and bad, so people understand the puzzle and the end pieces of the puzzle. But within that, they have to look at their work as something that is directly connected to competence development.
just stunning answers, aren't they? And I'm going to just say something incredibly practical, which is that when we set out on the journey of how did we develop people with the skills and the mindsets to take a quality improvement approach to this problem, we got very worried about where were we going to find the money to do this training. Turns out we've already got it.
Yeah.
Turns out we're spending a huge amount of money fairly randomly training and developing people in all sorts of conflicting, parallel ideas.
Yes.
And if you decide that this is your game plan, then I say all, but all you have to do is to have the courage to say, when we're doing our physician training, when we're doing our management and finance training, it's got this core. And everybody learns together on these basic principles. So it takes some organising, and it takes you to fight off people who kind of want to carry on doing their accountancy training or who just want to spend money. So you have to fight a few battles, but the resources are already in the system to achieve this. I don't know if that's the shared experience.
Yes, absolutely.
Thank you. You know, in all of the questions so far and the answers, you've all referred to culture and how the importance of culture. And I'd be very interested in your thoughts from your experiences. How do we go about building the culture of quality, safety improvement in the context of an overall organizational culture?
Can I start with something fun? Yeah, but I'm not sure that everybody think it's fun. But
It's a Swedish sense of humour.
yes, you know, culture is a very complex word, and it has so many levels and fragments. For me, culture develops when people think the same way. And to think the same way is a hard work, because then you have to go through, first of all, a safety thinking, minimize risk, having discipline, so you are not all the time afraid that something can go wrong. And then when you have the discipline to do what is expected and what is needed, then you can concentrate and do the art of the work. And when you do the art of the work together with someone else, then you start to think together. And when you think together, you say, we have a good climate, we are a culture that works together. But that demands first discipline and leadership, and then it demands some program and rules for how we should do it, and then it comes. So it's nothing that comes from somewhere. It is hard work to develop culture.
I'm not quite sure which bit of that was fun, but
It's so fun to think.
it's fun to think together. I agree. Yeah, I agree with that. And when it happens, you get energy. And, yeah.
Yes.
I think.
Just like us.
Yeah,
Yes.
yeah. I think hugely about this, and one of the things I think. So I'm not a doctor. The great joy and privilege of my career has been working with fantastic doctors on change. That's what makes our jobs worth doing. But I think there are things deep in the history of medicine that make improvement culture difficult. So the very things that built medicine as a career, now it turns out are difficult in terms of the kind of cultures we create. So examples would be, medicine is built on a very independent mindset as an individual. You know, at a time when your added value as an individual, given the limited knowledge of medical science, was probably what made the difference. And now we're the completely other side of that, where most of the time, not all of it, it's your value as a team player deploying understood knowledge and protocols that will make the difference, and only occasionally, and by default, should you be being incredibly creative. And so there's an inversion there. I also think there's a deep problem about the relationship between improvement and medicine, certainly in my country, in that in medicine we give value to the heroic response. So what we give value to is the save of the patient who was profoundly critically ill, or the fact that we ran the hospital today even though we didn't have the resources and we had too many patients coming through the front door. That's what people talk about, giving value to, the kind of heroic response against an uncontrolled situation. And when you lead quality improvement, you create the reverse. You create routine, smooth operations, and the culture doesn't give value to it. So one of the things when I was a hospital chief executive, before I did this job, we kind of did some, people in the organisation did some great work redesigning emergency care, and patient flow for emergency care moved from being chaotic and dramatic and lots of rescues going on to kind of smooth and ordered, and people didn't like it because they couldn't understand what their value was in the system. I used to go and visit the emergency ward and they'd say, "We're sorry you've come today, it's really quiet." And I'd say, "No, that's exactly what we want to achieve." And so I think as leaders we have to visibly communicate that these are exactly the things we value. We should, and you can do it symbolically. You know, you reward and recognise and talk about the person who operates brilliantly within the organised system of care, within the protocols, who values team above individual, who values order above kind of chaotic responses. And just the way you recognise and talk about what's great and pull people forward and acknowledge their performance and measure makes a real difference. But these are profound and deep changes in the relationship between the history of medicine and quality improvement.
I agree with both of my colleagues' comments. I think that the same is, in some ways, is true of leadership. The charismatic, powerful leader, what we would call a Superman or Superwoman, who swoops in and solves the problems and saves the day. And that's the model in which we as physicians, but also nurses, are trained. And so what we've said is culture and these assumptions are very deep, and they take decades to develop. And we said that unless we have a deep conversation about these things, we will not be able to sustain the change, because the way we see ourselves in the world, as you described, is very different than what the world needs. And so we had this conversation at the very beginning of our quality improvement journey, so 12 years ago, and we worked on what we call a new compact between our physicians and the organization. And then instead of autonomy and independence, we've now placed the priority on teamwork and collaboration and open dialogue. It was long before we ever discovered Toyota in our organization, or a method. And so it was fundamental, and we keep coming back to it, and now we hire our people for the compact. And when a physician applies for a job at Virginia Mason, they get a letter from me: "Thank you for your interest. Here is a copy of our compact." And 95% of people say, "This is really good." And about 5% of people say, "I don't want to work in a place that's that clear." And that is really good too, because you identify that in the beginning. And the other thing is accountability, that I think is so important. And for me, accountability may have negative connotations for some people. I don't think anybody will admit it, but they may not want to be accountable. And accountability for me means just being willing to receive feedback. And in healthcare, we have not had a culture of feedback over decades. And so part of being collaborative, part of being team members, part of having fun and learning together is also having a culture of feedback where we're willing to share our best thinking and tell the truth to each other. And I think that helps make us better, stronger, and helps the culture to then evolve in a way that is a patient-driven culture, what we think of as a patient-driven culture, not a physician or an organizational-driven culture.
I think one of the things you both say that's very powerful to me is about the explicitness of having the conversation together. When I've been involved in organisations that are very challenged, where things have gone wrong, there's a layer of conversation going on front of house, in the meetings, and then there's a whole layer going on in
the parking lot.
And they're completely different conversations. Right. And the authentic one is in the parking lot, and it's unhappy and broken and disturbed. And there's just a layer of code and unhelpfulness, and painful as it can be at the beginning, bringing that to the forefront is just fundamental to even starting this journey.
And it can be painful.
Yeah, it's hard, at first. Yeah.
Great, wonderful food for thought for us to take away. And I guess I'd like to ask any last thoughts or advice, or be careful you don't, or just from all your experience in your system. So I'd just love to hear anything else you'd like to share with us in terms of words of wisdom as we launch on this journey.
Gary mentioned earlier the need of having a focus on why we are here. If we use a sports metaphor, as we used before, we could say that we all love to play the game. And how can the leadership and also the owners help us to talk about how to play? Because that is the challenge, how to do it. And to come to that discussion, then you need a kind of value platform that you share together, and that is what Gary says, the compact letter then. But as a last word in this discussion, I saw the film with my family 2 weeks ago named Pay It Forward. And it's a simple film that goes to your emotions, but it's about a young boy who have a teacher that starts to encourage him to understand the idea that if everybody do 3 things for someone else, for 3 other people, and don't want to have anything back for it, you start a revolution. And systems as ours need that kind of people that love to do something for the work that they don't get paid back for, that they do because they want to play it better. So that is for me one of the burning points in improvement.
Thank you.
There are parallels, and just like us, I don't think you've been dealt the easiest of hands. You're taking on more change than anyone would suggest is sensible, and we're in exactly the same position. But that is where we are. So this is going to be a challenge, but also the level of difficulty also brings opportunities to tackle things that were otherwise people just put off. So in a way, harnessing the difficulty, figuring out a way of taking that kind of slightly oppressive or perhaps very oppressive stuff and using it to open up a channel. The other thing I would say, which is a very obvious thing, is, in the Alberta system, like in every system, you already have the leadership you need to do this. It may not be in the leadership positions. And, finding those people who have the energy and the will to go forward, there's just no doubt they're there. And finding them and giving them the support they need to take the stuff forward is always the most rewarding way of unleashing the sort of change that Goran describes.
I guess my final thought would be the importance of speaking to both the hearts and the minds. We have great ideas and great methods and great tools, and that speaks to the minds. We'll have great targets, but we have to have aspirations. And that has to speak to the heart. And I think to really lead and sustain meaningful change, not just change for change's sake, but meaningful change to create a better society, I think you need to appeal both to the hearts and minds. And I think that people across Alberta are depending on you to do that, and depending on your success. And I think that's a very noble calling, that keeping that very much in the forefront, I think will help you be successful.
Well, on behalf of Alberta Health Services, Mike and myself, thank you so much for your time today. It's just been a pleasure chatting with you and hearing your experiences and your thoughts and your learnings, and we so appreciate it. And thanks to all of you, and please enjoy the rest of the conference and the sessions, and have a terrific day.
Thank you.